see if that's good. So in DBT, what I'll say sometimes is that, let's see, what do I say in DBT? I lost my train of thought.
Something weird.
Something weird. It is. It can be uncomfortable. So I'll say, well, if you die, I'm not going to be there to help you. And I know you and I have been working on a lot of things, and I'm not going to be there to help you in the afterlife, and I don't know what happens in the afterlife. Usually I know what their beliefs are by now. And so I might say, so it sounds like, we're not quite sure what happens in the afterlife, but if problems come up, I'm not going to be there to help you. And I'd like to be able to help you, and I know for sure I can be here to help you with this stuff in life, presently. And that's what comes into attachment to the therapy or the provider, that the person finds you and the therapy helpful. If the person doesn't find you or the therapy helpful, then they're not likely going to talk to you about certain things, and they're not going to likely take your suggestions. So you want the relationship to be there. Oftentimes when I ask people about what has been helpful about therapy in the past, the patient will just say, they were just really nice and they heard me. They listened to what I was saying. But that doesn't mean that the only thing you do in therapy is say, yeah, that makes sense. For therapy to be effective, we want to do two things. We want the person to be heard, but we also want the person to reach the goal that they came in with, or solve the problem that they came in with. Sometimes that can be a pretty big problem and it can take some time, but we want to have those two things happen, because if the person comes in and just feel heard, they're eventually going to fizzle out because they're not getting what they came for. But if we're so focused on the goal and we don't talk about anything but the goal, then the person's going to not feel heard and they're going to back out and they're going to stop showing up. So you want to have that balance. If there's a fear of suicide, that can be a protective factor. Fear of social disapproval can also be a protective factor. Having a commitment to live. Now, again, this is not a contract for safety. This is just somebody saying, this is really tough, and I know I'm having suicidal thoughts, but I'm going to live. I'm going to do what it takes to live through this, because there's still more to experience and more to do. And if they're willing to follow a crisis plan or a safety plan, that can be a safety factor. And sometimes people will over-report risk. And so if they're really forthcoming, that's also a safety factor. So some of the outpatient interventions that we would want to do is offer hope but not promise it. We cannot promise that things are going to get better. But we do want to offer hope. So it might be things like, this treatment has been found to be effective. These antidepressants that you've been prescribed have been found to be effective. Let's give it 6 weeks. What do you think? And they might say, I'm willing to give it 6 weeks. And you say, all right, great. What else can we do to make this 6 weeks suck less? Stay very event-focused. So what we mean by event-focused is anybody can get overwhelmed with the immensity that is life. So we want to take things one event at a time and overcome each one by giving them easily transferable skills for other problems that they've been experiencing in their life. And so we want to stay event-focused so we don't feel overwhelmed. We also want to challenge their beliefs. So there is a difference between harmful and helpful thoughts. And when we think about challenging beliefs, we're not talking about challenging somebody's values or changing their values. What we are talking about is challenging their beliefs around the suckiness that life can be. And saying, okay, this moment really sucked, but what was important about this for the rest of your life? And it can be, well, I lost my job, and that really sucked, but I learned how to be graceful in the event of adversity. And I can apply that to my next job where I can be more graceful when really intense situations that come up. Something along those lines. So we're challenging beliefs. And sometimes challenging those beliefs occurs while they're practicing be another skill. When we look at managing suicide, we want to look at the problem right now, and we want to take a look at what happened to precipitate this suicidal thought, and we want to summarize that back to the person so we make sure we know what they said and what they, so we know that what we said matched what they experienced. And then, so we want to focus on solving the problem immediately. That doesn't mean getting the person's job back, right? Because that isn't always possible. So when we talk about solving the problem immediately, we are looking at how do we help you not commit suicide right now. So we want to look at their strengths. How have you gotten through these adverse times before? You can give advice, but it's not, you have to be fairly knowledgeable about the person to give advice. So you might say, well, who could you call in this situation? That's a form of giving advice. Or you could say sometimes when people are in this situation, they might have somebody that they reach out to, somebody that they trust that has also been in a similar situation or that knows you pretty well. Who might that be? So that would be a form of giving advice. So we have about 10 minutes before the break. And we are about halfway through these slides. So what I'd like to do I want to give you guys something. My goal was to have us do a suicide assessment and safety plan. So what I'm going to do is rather than continuing to go over these things, I have this, which has a lot of them on there. This is a risk assessment. So I'm going to give you this. It's double-sided. Then I'm also going to give you a safety plan. And what we're going to get started on is watching a video and doing the risk assessment. And we might only get through like the video before break. I just want to see if there's anything else on here. Okay, there's just a few other things before we go to that. So one is to get your own support. So if you feel like the situation is hopeless, you need support. You can't get sucked into the other person's hopelessness. You will. I have been. I've kind of said like, well, I don't really see any other options either. The person was really convincing for their case. And so I went to my support. I did the safety plan, right? I kept myself together. But once I got into my team, I said, I have no idea. I did everything that I was supposed to do. I went through the checklist. But I really feel hopeless about this person. And so my team, because I talked about this person before, or because I did a chart review with them in the moment, my team says, well, here are all the things about this person that's not hopeless. So how can you, as the therapist, buy into that? And then as I start to buy into it, that means that I can start eliciting that more from the patient. So do your own supervision and have your own self-care so that you reduce your risk for burning out with highly suicidal patients, or any patient for that matter. The rest of this about different risk level, I think we'll talk about as we do the example rather than by slide. And then on here, you will see some resources for safety planning, which could be, or for suicide assessment and safety planning, which could be really helpful. So let's take a look at Australian Ian. Oh, 16 minutes. That's not good. All right, let's do this. How do you guys feel about taking a break right now?
Real good.
Real good. I have bored you. Okay.
No, it's just heavy stuff, so.
It is heavy stuff. All right. So let's take a break right now, and then we'll come back at 22. That gives us 15 minutes. So we'll come back at 22, and then we'll get started on the example, and hopefully that'll be more interactive. How does that feel? All right, so if you're starting to feel pretty heavy about this, get outside. take a walk around the little thing that, what is that called? Like a courtyard that we have out there. Watch the leaves. Watch for natural movement in the leaves. People can leave as I'm talking to you, by the way. So watch for natural movement in the leaves. Do a little bit of mindfulness if you're feeling heavy. Okay. So we are going to do a couple of things during this video. You have heard a little bit about suicide assessment. You've heard almost nothing about safety planning. So you have in front of you, front and back, a suicide risk assessment. So what I'd like you to do while we're watching this 16-minute video is to identify a patient's risk factors and safety factors or protective factors. It is front and back, so you might have to flip back and forth a little bit. And also as you're going through this, and there isn't any place that's asking you specifically to write this down, but as you're going through this, consider observing the therapist and what you like that they're doing, and jot down some things you might want to steal from them as you're considering doing this with your own patient. So then what we're going to do afterwards is I'm going to help you guys maybe finish up the risk assessment a little bit and create a safety plan. The safety plan is the other thing that you have in front of me. I'm going to be the patient, I'm going to be Ian, and you are going to be my therapist, helping me create a safety plan. Okay? All right. So let's get started.
Okay, Ian, so you've been telling me that you've actually had quite a rough week this week. Can you tell me a bit more about what's been going on for you?
Things were bad, as you know. Last time I saw you, but I had a meeting with my boss this week, and
keep listening as best you can. I'm going to see if there's another way to turn up the volume.
performance. And I think that my depression's been getting in the way of
Is that enough light?
working properly at work as well. I've been able to concentrate and so on. So he didn't really think that I'd been performing too well. So my review was quite bad in a number of areas. And I don't know, I just feel as though it's just another thing that I don't really need to deal with at the moment, on top of everything else.
Okay. So it's leaving you feeling quite overwhelmed?
Yeah, overwhelmed, just don't know if I can handle it.
Okay. When you say that you don't feel that you can handle it, what kind of goes through your mind thinking about that?
It's just one thing on top of another, on top of another. And no matter what I do, I just,
Do you guys want to start over?
you know, I can't seem to see how things are ever going to get.
Okay, Ian, so you've been telling me that you've actually had quite a rough week this week. Can you tell me a bit more about what's been going on for you?
Things were bad, as you know. Last time I saw you, but I had a meeting with my boss this week, and it was about my work performance. And I think that my depression's been getting in the way of working properly at work as well. I've been able to concentrate and so on. So he didn't really think that I'd been performing too well. So my review was quite bad in a number of areas. And I don't know, I just feel as though it's just another thing that I don't really need to deal with at the moment, on top of everything else.
Okay. So it's leaving you feeling quite overwhelmed?
Yeah, overwhelmed, just don't know if I can handle it anymore.
Okay. When you say that you don't feel that you can handle it, what kind of goes through your mind thinking about that?
It's just one thing on top of another, on top of another. And no matter what I do, I just, I can't seem to see how things are ever going to get And,
So it's very, very hard with all of this happening, with your financial problems, with having having difficulty at work because you're feeling so depressed with your concentration, to ever even think that things might get better. Okay. Does that kind of make you feel that it's kind of not worth it at the moment?
yeah, I don't think that anything I can do is going to help me get out of this
Okay.
rut.
So feeling quite helpless.
Hmm.
Okay. Does that make you think at all about wanting to end your life? It does. How often is that coming up for you?
Yeah, it's a lot since the review in the last few days.
Last few days. Okay, so you having those kind of thoughts going through your mind? Do you have any time when they're not going through your mind?
Not much.
Not much. Okay. So tell me a bit more about what actually goes through your mind when you think about this.
I think it'd just be a lot easier just to bow out.
So that seems like a kind of an option that would work. Okay. Have you thought about how you might do it if you were to bow out?
Yeah.
Okay.
So it's a little bit hard to talk about.
Take your time.
Probably, the medication that my GP's put me on.
Right.
I don't know much about it, but I'd imagine if I took enough, it'd be enough.
Okay. So when you think about it, you think, well, if I took all the medication that I have, then maybe that would be enough to end my life?
I think so.
Okay. And, you're obviously here today. So what has stopped you so far from actually acting on those thoughts?
Not much. I don't know. I don't like the idea of my daughter thinking that I didn't have the guts to stick my life.
Okay. So that's something that kind of stops you when you think about her?
A bit, yeah.
A bit. Any other things?
I'm from a fairly religious background, I suppose. And
Does that feel for you that kind of are stopping you from so far from having kind of done it? Okay. And are you aware, Ian, of kind of what you're hoping will happen? Because sometimes I know when we're feeling this desperate and we're feeling very, very overwhelmed, we get a sense of we just want things to stop versus maybe wanting to kind of to die. So I'm just trying to understand what it feels like for you.
I just wanted to stop.
You wanted to stop, okay. So it seems that saying taking all the pills that you had would be one way of having a solution to your problems. Okay. But when you think about that, what stops you from actually doing anything is the feeling of, what your daughter would feel like if you did it, and also that it kind of goes against your beliefs. Okay. But it must seem quite overwhelming to have those thoughts then.
Yeah. It just seems like the only way.
The only way. Okay. So has it been quite hard for you in the last while as well, in the last week since you had the performance review, to focus on the things that we've been talking about in terms of the things, looking at strategies that may help you to start to feel better?
Yeah. I'm sorry, I haven't really given that much thought.
Okay. So that's been really, really hard to hold on to. Okay. So I just want to kind of check, have you still been going to work since the performance review? What have you been doing?
Spending a lot of time in bed.
Right.
Just sitting around the house. looking at photographs.
This is of your
My wife.
girlfriend. Yeah. And the more you do that, does it make you feel worse? Okay. So it would seem that we're in a kind of a dilemma here. There's on one hand you have this one option that would seem to solve all your problems and that it would stop, it would make everything stop. But on the other hand, there's a part of you that doesn't want to do that.
Yeah.
Okay. How strong do you think that part of you is at the moment?
Not very.
Not very?
No. No.
Okay. Say in a percentage-wise, which part feels stronger? The one that says, okay, well, let's just go home and take all the pills.
It's much stronger.
That's much stronger. Okay. Have you been collecting the pills for that?
Only the ones that I've
Only the ones
got
that
the
you've got.
doctors given me.
So those are the antidepressants. that
And
you've
the
got.
sleeping tablets.
Okay. Right. So I'm wondering what, because this is quite concerning in a way, and I'm quite worried about you in terms of going home and feeling like this and having to deal with the struggle. Do you have any ideas of what you think might be helpful for support for you at this point in time? It's hard to even think about anything else rather than this point. Okay. Do you have, because I'm wondering how helpful it is for you to sit at home, kind of looking at photographs, kind of thinking constantly about your wife and that she's not there and those kind of things, how almost that makes you feel worse. So I'm wondering maybe during the time while you're feeling like this, whether we can think of anything that may help you to kind of feel more supported, to feel less alone.
I could give John a ring, I suppose. He's my brother.
Right.
Go and visit him and his family.
Mm-hmm. Do you feel that you'd be able to do that? Mm-hmm.
I don't want to burden him with all of this stuff. Just because my relationship's in the toilet doesn't mean he has to suffer all of my misery as well.
Okay. So you worry about being a burden to him or putting your problems on him. Okay. Would he see it that way?
Probably not.
Probably not. Because you've described him as being quite supportive and
That's great.
and that you normally have quite a good relationship. Okay. So do you feel that you could contact him, say, after the session, or would you prefer to do it maybe together?
I can give him a call.
Mm-hmm.
Yeah. I can do it after the session when I get home.
When you get home. Okay. Because, as you were saying a bit earlier, sitting at home and looking at photographs, and I'm assuming probably your sleep is still quite affected as well from what you were telling me in the last session, and how are you eating at the moment?
Not much over the last couple of days. I haven't really felt.
You haven't felt like eating at all, so it's really been hard to kind of look at anything else than I just wanted to stop, and this is my kind of way out of stopping. But it kind of goes against kind of our religious beliefs and feeling that this wouldn't be very good for your daughter as well. Okay. So maybe there's a time where you could be with someone, with your brother, and just to help you through this really kind of tough time until we can start to work on looking at other things that might be more helpful for you. How does that sound to you?
It's something, I suppose.
Yeah?
Mm.
Okay. Would it be helpful for me to maybe give you a call later on to see whether you have kind of contacted your brother and managed to talk to him? And
I can call him. Yeah, I can do that.
you sound like you feel quite confident that we'll do that.
I can do that.
Okay. As you can see from that scenario, Ian was quite depressed and feeling quite helpless and hopeless, and was admitting to having constant suicidal ideation, or thinking about that he wanted his problems to stop, although he wasn't saying that he was actually wanting to die. Now, what would be important is to take enough time to actually do a thorough risk assessment, and it was clear that I hadn't been able to get all the information that I would like to in the brief 10 minutes that you saw. Some of the things that will be important to get from Ian would be whether he would actually make an attempt, in that how likely did he feel that he would actually act on his thoughts. So asking things like, how likely do you feel that you would act on the thoughts that you're having? So if you were to go home now, how likely do you feel that you might actually take the antidepressants, and how many do you think you would take? The other thing to ask him would be whether he'd actually done a trial run, whether he'd taken any extra antidepressants and how that had gone. And hopefully this is something that I would have done in an assessment interview with him, was to find out whether he'd had any previous attempts of suicide and what those attempts entailed. Now, Ian had said that he would phone his brother. However, it was unclear as to when he might do that, or how safe he was at that point in time. So the other thing I'd want to find out is the imminence of the risks, or how likely he felt he was going to act on these thoughts, in addition to then maybe making sure that he actually phoned his brother whilst I was in the room with him. Because sometimes clients will say, yes, they'll do this, but they may then leave the room and actually not do this. So the really important thing to think about is, how safe is this client to leave your office on their own? He mentioned a couple of protective factors, in that he didn't want to hurt himself because of his children or his family, and these are always important things to find out, and his support structure in who was around that would help him over the time where he was feeling at his most vulnerable. The other thing that you may have noticed when you watched the video was that I tried to engage him in trying to think of solutions and to get involved with what might help him to feel better and what might help him at that point in time. Because often clients who are feeling suicidal or are feeling that there's no hope kind of lose their ability to feel that they can make decisions or actually take action within their lives. So trying to engender that is a really helpful thing to do, and engenders hope. The other thing to think about when you're doing risk assessment is that it usually takes longer, and you could see with Ian is he was quite depressed, and it took him quite a while to open up and to talk about what was going on for him. So if you're having another client booked in right after, you've got to think about that this is going to upset your timetable. You can't just say, well, it's the hour has ended and okay, off you go. Because again, you've got to ask yourself, is this client safe to leave? So it just takes as long as it needs to take for you to get all the information that you need. Thinking about the means is another thing that's important. He mentioned that he was taking antidepressants, and having knowledge about how lethal the means are that a client is thinking about is important. So for instance, if they're saying they're going to shoot themselves, finding out whether they actually have access to a gun, or whether they know how a gun works, or whether they have access to bullets, are things that are important to ask. So knowing the lethality of the means is another important thing to think about and to find out. So there's quite a number of things that you need to find out when you're doing a risk assessment. It's the intent, how serious are they, and how soon do they...
Okay, so could somebody hit the lights for us, please? Alright, so what do we know about Ian? What do we know about Ian so far?
He has a strong support system.
He has his brother, right?
Yeah.
He has John. Yeah.
And his daughter.
And his daughter.
And his wife.
Tell me about his wife.
She passed away.
Did she pass away?
She's gone.
She's gone, and he said, if I call John and talk to John about my relationship being in the crapper, I think he said, then, you know, I don't want to put that in John. So we don't know where the relationship's at exactly. But it doesn't sound like it's going good. Yeah, so we know his daughter is a safety factor or a protective factor. We know John's a protective factor. What else do we know about Ian?
He has some set of religious beliefs that are prohibiting him from going through with it.
Yep. That's a protective factor. What else do we know about Ian?
There's a few stressors in his life. He's broke and his job is not going well. He just got a negative review because of his depression, which probably compounds his depression.
Absolutely. What else do we know? History of depression?
We know he's had suicidal ideation within the last couple days.
Yep. What else do we know about him?
He feels hopeless.
Yep. What else?
He seems he's medicated.
Taking pills.
He's medication. Yeah.
Yeah, and he eats some pills to anti-depression.
Yeah, he has antidepressants that he's taking. He's also taking a sleep aid or has been prescribed a sleep aid. He's not collecting the pills yet, but he has some. He hasn't finished the bottle yet, so we know that he has some. We don't know how much. What else do we know about him?
There's no appetite.
He doesn't have an appetite. He has poor sleep. Yes. Go ahead.
He feels like a burden to his brother.
That was an interesting one. I don't know if he feels like a burden yet, but he's worried that if he does talk to John about his relationship and his problems, he could pull John down with him into feeling like a burden. So that one was a gray area, but I'm glad you picked up on it. What else? Because it means he has a support, but he might not be willing to use the support. What else?
He doesn't see like other options.
Yep, so he feels overwhelmed and he's pretty narrow.
He's like laying in bed a lot and maybe not going to work as consistently since the negative review.
Exactly. Right. What else?
He showed up in the office.
He's coming.
Pulled himself to the office.
So he has some attachment to the therapy or the therapist. What else? He has concentration problems, he mentioned. How do you know he has suicidal thoughts? What statements did he say?
Bowing out.
You know, it'd be a lot easier to bow out. What else?
I can't handle it anymore.
What else?
Lots of stuff.
Yep, what else?
A lot last few days.
It's been a lot in the last few days. Yep, what else? It just seems like the only way. Was another one I wrote down.
Solution to the problem.
Seems like a solution to the problem.
Don't have the guts to stick with my life.
Well, he said to his daughter, that was actually a protective factor. He said, I don't want my daughter to think I don't have the guts. So you have to listen carefully because some of these things go either way. The other thing you want to do is you want to have as much in quotes as you can, because it can be, when you talk about this in case review or supervision later, you want to be as specific as possible. Yeah?
I have a question about that regarding your patients. So when I was speaking with one of my clients and he was telling me about a difficult time in his life, I wanted to take notes, but I felt like that was not the time to not be present for him there. So how do you do this good note-taking and quotations if you are in the middle of a very deep story, a very difficult story?
You don't look at what you're writing. You just write it on the paper. Some people will come up with a grid on how they take notes instead of like this. Because when you're doing something like this, you have to be like, oh, where am I on the page? But in a grid, you can just kind of jot things down. You don't write full sentences unless they are incredibly important sentences. So you get themes as much as you can. Yeah, and then you write your note as quickly as possible after the session so that the next patient doesn't influence the last patient, if that makes sense. There are sometimes at the end of the day where I'm like, I met with Steve. What was going on? And if I did not have my notes, I wouldn't even remember that I met with Steve. Because there's a lot that happens in a day and a lot of different stories that you're hearing from people. So I don't look at what I'm writing. Yeah.
Did you always make sure, like, the first time to ask that it's okay with them, then?
there was a time that I did that, and now I tell them I'm going to take notes that while we talk so that I can ensure accuracy in your chart. That's what I say. Or I might preface it with, when I meet with people, I want to make sure I understand you as well as possible, and it's helpful if I jot down some things while we talk so that I make sure I'm understanding. And then when I'm repeating things back to them, sometimes I'll say, you told me about that Steve was really important to you in your life. And so then I'll reference them and they're like, oh, this person's paying attention to me. But if you're just like, okay, tell me again, what did John say? Then it's a barrier. Yeah, there is an art to note taking that you'll figure out how it works for you. Some people have really great memories. I don't. I have to take notes. I can't do my job without it. Yeah. All right, so with the suicide risk assessment, what were some of the protective factors that you noticed? His religion.
His role as a father.
His role as a father. What else?
We don't know of any prior attempts.
We don't, so we'd have to ask about that.
Potentially his relationship with Brother John.
Yep. And he also had ambivalence, right? He said not very much of him is towards life. The more of him right now is towards death. But there is ambivalence there, and we want to exploit that ambivalence towards life to our benefit. Okay, so what I'd like you to do is I'd like you to get out your safety plan. We already know there are a lot of things missing, like past suicide attempts, family history. We know he has a method in mind, so he has a plan, but we don't know when. We don't know his intent level. There are some things we don't know. But let's get out our safety plan. Let's assume that you made the judgment that his inpatient was not appropriate, but he just does need some planning between now and the next time you see him. What do you already have on your safety plan? You already have something. She gave you a free space on your safety plan. What did she mention that could be safe? A support. His brother, calling John. So she also has in there that John would not see him as a burden. She did assess for that. He feels like he could potentially be a burden. She asked him about it. He said, no, John would likely not see me as a burden. So that's a protective factor. So we need to build on that belief. She challenged his belief system in that moment, and we need to build on that belief. So you guys are my therapist. My name is Ian. It's really nice to meet you. And I would like for you to help me fill out the safety plan. So you can ask the questions however you'd want. You can ask it in order or all over the place. It doesn't matter. We're just trying it on. I'll go first. So, Ian. Oh, you want to go first? Oh, okay. So, Ian. Yes. We've been talking a lot about these thoughts that you're having. What are some of the things that you might notice that lead to these thoughts? As Ian, because I just took on the therapist role, what might lead to these thoughts?
Staying in bed and looking at photographs.
Staying in bed.
Looking at photographs.
Looking at photos. Of what?
His family. His wife.
Good. All right. Who would like to go next? I'll be Ian again.
Would you include something like feeling like it's not worth it or feeling hopeless with the verbiage that he used, or is that just too general? Let us do something concrete.
Ask a question and we'll see how you're going with it. How about that?
Would feeling like you can't do anything increase your chances of wanting to kill yourself?
I would ask a more open-ended question. How would you put that into an open-ended question?
When do you feel like you may want to kill yourself the most?
When I'm thinking about work and, I just can't do anything right there.
So when you feel like you can't do anything right at work, then you may start feeling suicidal.
Yeah. So usually I'm filling this out while I'm asking the patient questions because it's really hard for the patient to fill this out and think and talk to you and feel overwhelmed at all at the same time. So I just fill this out myself, but yeah, good. What's next?
So Ian, we were talking before about how calling your brother might be helpful. Are there any other things you've done in the past to help you get through these hard times?
Well, there are times when I'm laying in bed and I'm looking at photos and I'm feeling really crappy. And I just can't believe what transpired with my relationship. And there are times where I get really mad. And I just have to get out of bed because I'm mad about what happened. So I get out of bed and I take a shower and try to reset.
So taking a shower usually helps?
A little bit.
Does allowing yourself to feel other emotions like anger help?
I mean, oddly, I guess when I'm angry at myself, but like, it is a different feeling. I don't, laying in, like when I'm angry at myself, I feel more like antsy, so I don't, like it feeds into the depression, but it also kind of, I don't know, I just have that, I need to move.
When you feel like you need to move, do you ever leave the house?
Not really leave the house. No, because I don't want to be irritable at other people. So you have these 6 things. Feel free to ask them fairly directly. You don't have to come up with a clever way to ask things.
I have a question. Sorry. I have a question. So how do you like walk the line between like giving advice? Like when we're talking about do you ever leave the house? Like you wouldn't want to say like, have you tried going for a walk, right? Because that's
You would
like
say
giving...
sometimes people find it helpful to go for a walk.
Okay.
Is that something that would be helpful for you? You couch it in other people have found success with this.
Okay.
Not that I'm giving you advice, because you don't want to sound like somebody's mom.
Yeah. Okay.
Even though moms are wonderful and they're usually right, you don't want to.
Right.
That's not the therapeutic relationship. Yeah. All right.
Who else can you ask for help besides your brother, John?
I mean, I have some coworkers, but I don't know. And I have some friends, but I feel like they all went to my wife.
Can you think of one other person that you could call besides John?
I mean, I guess Jeff would be okay. I could call Jeff, but not really. I don't really want to talk to him. I mean, like, he would be more just like a distraction than actually talking about my feelings.
Okay.
Those for your informal networks, have you ever thought of formal support systems that you could try on?
I mean, there's like this single dads group that people keep telling me to try, but I don't feel single yet, so I don't want it to go and feel like people are gonna hook me up with people. So even though Ian doesn't want to go to the single dads group, you still put it on there. You still put it on there as number 3. Why would you do that?
Because you could invoke it, right? It can be part of his plan that if you feel this way,
you get to do
your
these
plan
things.
is to do this.
When Ian is feeling depressed and suicidal and it feels like the only option, this list is meant to be his memory. When we are in certain emotional states, we forget a lot of things. Our brain goes blank. And so this is there to be helpful, to be your memory for you. So you can say, Ian, we came up with a lot of stuff today. When you leave here, if you're feeling depressed again, your mind may go blank. Get this out. Take a picture of this and have this be your wallpaper on your phone. Tape this to the door, to the bathroom mirror, to the top of your photo book, your photo album. Put it there so that you can see you have other options. Because it's okay to like mourn the loss of the relationship and look at photos, but it's also okay to get out of bed and be angry, or it's okay to feel other emotions. So far we have 3 warning signs, 2 internal coping strategies. Let's explore some other coping strategies. I'm going to be Ian, or I'm going to be the therapist, you guys be Ian, okay? So Ian, we talked about getting out of bed is helpful and taking a shower is helpful. What else has changed your mood, even just slightly, when you're feeling down?
Playing with my dog.
All right. What else?
Being with my daughter.
How often do you see your daughter?
2 times a week.
2 times a week. Okay. So you're seeing her twice a week, and when you're with her, how do you feel?
I guess happier than normal.
Happier than normal? Okay. So some of that sadness evaporates when you're with her. Right. What else could you do to take your mind off of these problems without contacting another person? What activities could you do?
Sometimes I like going to a movie by myself.
A movie by yourself? That's wonderful. What else? Exercising? What do you do for exercise?
Yoga.
Yoga? That's fantastic, Ian. So here, and what I really like about yoga is that you can do it alone. You don't have to go to a studio for it. So here we started with you in bed looking at your photos feeling hopeless. And you and I have talked for a few minutes and we've come up with 6 other things that change that hopelessness. It doesn't change it forever. And sometimes you're going to want to revisit that photo album. And you're going to want to revisit those thoughts about your wife and your relationship. And that's okay. And that's something you and I can work on and revisit together even. What is it like to know that there are 6 other things that are options in your life other than death? To help you get out, to help you make it stop. What is that like for you?
Feels a little better.
Feels a little better. So earlier we talked about that the majority of you is thinking about death and taking the pills, and there's a small piece of you that's thinking about life and not taking the pills. How does knowing that there are these 6 things out there that sway your emotion, how does that move the scale with the suicidal thoughts? Ian, you're being very quiet. How does that tip the scale for you?
It makes me think that I should maybe try to focus on these things a little bit more so I'm not so clouded with my suicidal thoughts.
So it tips the scales just a little bit. And so that's our goal, is each week to tip the scales just a little bit. Because what you're going through right now, Ian, is really tough. It's very hard. And there are a lot of emotions that I don't want to take away from you. Because this is a sad situation. Your sadness makes sense in this situation. But what we want to do is help the grief work. And we want to help you be able to live a full life with your daughter. So you mentioned John as somebody that you could call and ask for help. We talked about the single dads group as potentially being distracting or maybe even potentially helpful. Are there any other people that you could contact? Let's assume Ian says no. So here, Ian, what else I have for you is professional agencies you can contact during a crisis. I'm going to write down my number. I'm also going to write down the emergency person at our clinic that you could contact. We have a person in our ER that's available. But I also want you to know that there are going to be times where I'm not available, where it might be after work and I won't have my phone on me. So that would be a time to call these other emergency resources. And here you can see the Suicide Prevention Hotline, which has actually changed its name to the Crisis Hotline. And so it's 1-800-273-8255. It's written down on here. If you're a veteran, press 1. But if you're not, they're available 24 hours a day. They also have a text and chat version that you can access. And I'm gonna write down some of your local services that are closer to you. So your local ER is always available. Here at the University of Michigan, we have psychiatric emergency services. They're available 24 hours a day, and there's somebody you can go in and talk to. But I also noticed that you live closer to St. Joe, so I'm gonna put down St. Joe's contact information as well. So what are some of the ways that we can help make your environment safer, Ian? Because that thought might come up spontaneously for you again. What can we do to make your environment safer?
Not keep medication I don't need to be taking around.
Can you flush some of your extra medication or dilute it and then turn it in?
Yeah, take it back to the pharmacy.
Okay, so you can get rid of meds.
I'm flushing it because it makes the fish unfrozen.
I know, they don't always need it. No. So you can turn it back into the pharmacy. If the pharmacy is not available, is there a way that you can dilute the medication and not have access to it? Or can you give it to anybody?
Maybe give it to John to hold for me,
John can
or
take it.
I've heard that you can put it in kitty litter. Is that true?
I don't know. I haven't heard that one before, but that's an interesting concept.
How do you dilute it? I don't know.
One way that's been suggested is just, okay, I'm about to tell you something that I don't actually understand. Rather than just throwing it down the toilet, you're supposed to dilute it first and then throw it down the toilet, which makes no sense to me. So anyway, sometimes people will dilute it and keep it, but then you can drink it. I don't know. Take it back to your pharmacy. You can also take it to the police station oftentimes.
Okay.
I have a friend who's an MD, and she says your best bet if you don't have access to those things is just peel the label off of it and put it in the trash can.
Yep, and then it just goes into the landfill and gets buried. Yeah, there's no good way to get rid of meds.
Right.
Anyway, back to our role play. So what are some other ways you could give your meds to John. Sometimes people find keeping just a week's supply on them is helpful if they're concerned about taking it. What would it be like for you, Ian, to get meds from John each week, or have John deliver you some meds each week? Or have a delivery system with your pharmacy each week? What would that be like for you? Is that doable? Yes, that's my need, yeah, okay. So weekly meds. So one of the ways to keep your environment safer that's kind of going to be maybe a little uncomfortable, but what would it be like to have somebody hold on to that photo album for you for a little while? What would that be like, Ian?
That would be really hard.
It would be really hard. It would be really hard. What do you like about the photo album?
It makes me think of better times.
So there are times where it really gives you a lot of joy to look back at your wedding photos of the birth of your daughter. What leads you to have negative thoughts about the photo album that brings your mood back down?
Well, I think all those good times are behind me.
They're behind you.
I have nothing to look forward to.
Nothing to look forward to. So they have moments where it spikes joy and moments where it really spikes depression feelings. So knowing that that photo album will never be destroyed, what would it be like to hand it over to somebody or put it in a safe deposit box just for a little while we figure out other ways to decrease the depression in your life, knowing that you can revisit those memories anytime you want in your mind? What would that be like? A little bit of a relief. So what do you make of this questioning Ian and giving him a suggestion and kind of trying to problem solve how to make it happen?
So I think it's a great suggestion because you're providing him with an idea that might eventually help him move past being stuck in this moment. But I also think that something like that he has deep emotional attachment to, until he is ready to put that away somewhere, it's going to be very hard for that to...
It's going to be really hard. Yeah, getting rid of a stimulus is really hard for folks. And so putting it in a safe deposit box or putting it someplace where they have access to it, but it's just not there every second, will help decrease the impulsive decision to go look at the stimulus or get the stimulus. And so if we can just put a few steps and between them and the stimulus, it can be really helpful. And also reassuring them that you can revisit this in your mind anytime. But one of the good things about getting the stimulus away is that when they think about it just spontaneously, it won't be for as long as if they had the stimulus. Because with the stimulus, they're re-stimulated over and over and over again. It's the reason why we all binge watch Netflix, is because it's just right there. But if the cable goes out, you're like, I guess I gotta do other things for a little while until the cable comes back in. It just re-stimulates you to do the same behavior, to have the same mood. So we wanna change that. So how do you feel about Ian's safety plan? Yeah?
I feel like one of the things that we haven't really done, I don't know if maybe this is intentional, is we haven't really done anything to address steps he can take to get to the root of some of the problems.
We have not. That is different than a safety plan. So that's where attachment to the therapy comes in. And you could put on here, one of your internal coping strategies could be, I'm working with my therapist to figure my crap out, my stuff out. That could be one of your internal coping strategies. Your other internal coping strategies, if you've been working with Ian for a while, you could say, we talked about cognitive restructuring. What are some cognitive, what is the word I'm looking for?
Skills?
No. I'm just going to use negative beliefs because cognitive distortions. Wow. Okay. What are some cognitive distortions that may start leading you to feel suicidal thoughts? If they don't have the language for that, though, you wouldn't bring it up spontaneously. So, but if you've been working on this, you would say, what are the cognitive distortions? And they'll say, well, I'm shoulding about the past, or I have a negative filter about the past. If they have the language, use it to your advantage. And then say, okay, you have that, what can you do? And they can say, I can use this cognitive restructuring that we've been using. So that can be part of their warning signs and part of their internal coping. Mm-hmm. But if we haven't talked to Ian about that, then you might say, would you be willing to continue to work with me on these things? Is there hope in that? You're not contracting for safety, you're looking for hope. So you'd say, how does working with this therapy impact your level of hope? And they might say, it does. And if it doesn't, I mean, if you can't get any answers to any of these, then inpatient treatment might be indicated.
If you're struggling to come up with internal coping strategies, is there a negative side to going into the past to get them, and how far?
No, you can ask, well, how might you ask that question? That's a really good one. How might you ask it?
At a time when you were very happy, what were some, or when you're using coping strategies effectively, what were they?
Yeah. You can say, what was your life like when you were really, really happy? How can we implement some of those strategies now?
Is there any risk of, like when saying, like the hopelessness that the good times are behind, or something that creates a separation between not being able to do those coping strategies because everything has changed and they're hopeless now?
Well, they could say, right, all those good times were around my wife, and my wife's gone, so I can't replicate those good times anymore. So another thing you could ask is, when you've had struggles in the past, how'd you get through them? And really elicit their strengths in that way. Okay. So this gives you a taste of what a safety planning might look like. How many of you think you're going to encounter somebody who has suicidal thoughts this semester at your field placement? At least one person, maybe two. At your job or something? Okay, in the next year maybe? Yeah, definitely. So when the time comes, when you start, how many of you are seeing patients already? A handful of folks? Okay. These slides are going to be, how many people have had suicide assessment training in classes, job, field placement, a couple people? So take that information, take these slides, take these forms with you into your placement, and see if they're conducive with your placement, or if you can add them to your experience, and keep reviewing this. I will tell you that in reviewing these slides, because I review these each year, because when I teach a class, I review them, and then when I guest lecture for this, I review them, and each time, I'm like, oh, right, I totally forgot about that day today. Mm-hmm. So this is not the last time you're going to be learning this or relearning this, but review these often when you're with a patient that you think might have suicidal thoughts. Okay. Now, in the last 30 minutes of our day, we are going to move to substance use. And we're going to go through one more